Hi, my name is Judith Puzon, and I'm the Director of Care Management for University of Washington Valley Medical Center, located in Renton, Washington. Valley Medical was founded in 1947 and is the oldest and largest public hospital district system in Washington state. We serve over 600,000 residents in Southeast King County, and in addition to our hospital, VMC operates a network of more than 4 dozen primary, urgent, and specialty care clinics in Southeast King County. Here I'm sharing a couple of maps with you. This map is looking at social determinants of health, the health of our community. Dark red areas are areas that are most negatively impacted by social determinants of health, and dark blue areas are least impacted. As you can see, the white line represents our hospital district lines, and Valley is located about here. Therefore, we are surrounded by individuals who are at risk of many social determinants of health. In addition to our community health and housing issues, our population is also one of the most ethnically diverse groups in the King County area. During March of 2020, Valley Medical Center experienced its first surge of COVID-19. Community members were fearful and triage phone numbers tripled. RNs were exposed to patients who literally were ill and possibly at risk of dying in their home. They needed access to urgent and emergency care. Testing was limited and hospital surge was imminent. With those facts in mind, we needed to pivot to serve patients in the community and create access where access wasn't usually present. RN care managers from our outpatient care clinics partnered with our mobile care unit testing site. The mobile care unit was responsible for testing of COVID patients who thought they had been exposed to COVID. And patients who tested positive at that site received the opportunity to enroll in the RN Care Manager program. In partnership with our infectious disease provider group, we created a plan of care where patients who were experiencing symptoms days 5 through 12 of symptom onset would receive daily phone calls from the registered nurse. The nurse would evaluate their symptoms utilizing symptom-based algorithms, formulate an assessment and a plan. If needed, we would consult with our infectious disease providers for unusual circumstances. In April of 2020, we added on to our program by giving every patient who tested positive for COVID a pulse oximeter at home and created a home surveillance tool for right side of care and recommendations for our population. Patients who improved would be graduated on day 13 to a phone call every 2 to 3 days, and patients who continued to struggle with resolving issues or secondary infections would remain followed by the RN. During this time, we enrolled 2,612 patients and graduated 2,496. Hospital readmission rates during March of 2020 through March of 2021 were consistently lower than historical rates. We received consistent positive feedback from providers as well as patients. Our partnership with the infectious disease department and support and consultative support for the RN care management facilitated knowledge to help guide patients to early entry, prevented known complications associated with rapid deterioration, and hopefully preventing the need for ventilation. The goal, safe in-home care plans developed to support right care at the right level. COVID taught us to be nimble. Innovation was abroad throughout the organization. We used critical thinking as our source of truth, as many of our tools did not reflect or integrate knowledge for COVID. This required, during our initial stages of the pandemic, nurses who were conducting triage did not have a tool for COVID or symptoms related to COVID. We began using existing symptom triage tools such as shortness of breath or fever, and we integrated those tools in such a manner to support our population. The community phone line was our best representation of community outbreak. Calls would increase when they increased prior to each wave that we had. And when calls escalated, patients then would be increased to the respiratory tent as well as the EDs. So as long as we paid attention to the phone lines, we would have indications of what was coming. During COVID, we had rapid and continuous change. And during this time, we demonstrated robust ability to engage in process improvement. Though we didn't acknowledge it at the time, it felt like we were constantly living PDSAs. In terms of looking at what we can learn from COVID and take to disaster planning, things that I think about are what can we hardwire, what did we do well? During this time, we learned that our command center processes worked well. Communication was never enough. And more importantly, not only to have communication, but a singular source where all new tools and communication information for both the staff and the public facing side could be located in a central area, one side for the public and one side for the staff. In addition to that, we had very successful deployment and support from our facilities departments to create tents and support us during adverse weather conditions, such as snow and windstorms. And all through this, what we learned, of course, is the importance of standard work and processes. I thought I'd end this brief foray into our experience of COVID with this patient story. This is Mary, and Mary had asthma, and Mary could hardly eat or drink or get out of bed. Mary expresses gratitude to the nurse who cared for her during this time, who called her daily, who prevented her from going to the hospital unnecessarily, and kept her safe without a hospital admission. Mary thanks us, and I thank you for the opportunity to share our story.